Okay, it's 1 o'clock. So welcome to the Indonesia Project Global Webinar Series on the coronavirus pandemic. This is the 5th seminar, and you can find the Zoomcast of the previous 4 seminars on our website at indonesia.crawford.anu.edu.au. My name is Arianto Patunru, and I'm here with Nur Kamala Mulyani and Baskara Adiwena. The Indonesia project would like to thank ANU and Australian DFAT for their support. Our guest today is Dr. Panji Hadisoemarto from the School of Medicine, Universitas Padjadjaran. He is also a senior researcher at the Sustainable Development Goals Center at Universitas Padjadjaran. Panji studied public health from Georgia State University and Harvard University. He once worked with the US Naval Research Unit 2, where he was involved in studies on dengue fever and avian influenza. We have asked Panji to talk about the current situation of the COVID-19 pandemic in Indonesia. And today he will start by analyzing the epidemic trajectory of COVID-19, compared it to those of other epidemics Indonesia has experienced, such as dengue and tuberculosis. He will then discuss some policy options, also with a comparative perspective. We will have a session for Q&A after the presentation, but feel free to write your questions if you like anytime on the Q&A box. We will attend to it later, along with questions asked directly via raise hand feature. So now let me invite Panji to start his presentation. Panji, please share your screen and take it from there.
Thank you, Pak Arianto. Hello, everyone. Good afternoon. So let me start my presentation. Give me 1 second. Share my screen. Okay. So I hope you all can see this.
Yeah, that's good.
So my name is Panji. So I have been working at the Padjadjaran University in Bandung since 2005, and for the past 4 years I've been working in the Center for Infectious Disease Research in the Faculty of Medicine, and mostly worked on tuberculosis. But my work really started with dengue hemorrhagic fever ever since I was just graduated from the medical school, and that was in 2005 or 2004. Yeah. So dengue, tuberculosis are two diseases that are near and dear to my heart because I've worked on it for several years now. And COVID-19, of course, it affected me personally because right now I'm in New Zealand, caught in a lockdown. Couldn't go back to Indonesia. I was planned to be back in Indonesia a couple of weeks ago, but everything was closed, so I couldn't fly back to Indonesia. And now here I am experiencing how COVID-19 is affecting our lives. And of course, as an infectious disease epidemiologist, COVID-19 is always of interest. But this presentation may be a Herculean task for myself, and I will do my best, but please do not expect too much because this is a lot of work to be done in just a few days. What I will try to do is not to have an in-depth study, but just a cursory comparison of Indonesia public health response to COVID-19 and do my best to compare that to that of tuberculosis and dengue. Okay. And in the end, I was asked, so at the beginning I was asked whether in the dengue or TB, whether COVID-19 will be the next tuberculosis and dengue for Indonesia. That is a very hard question to answer, but let's see if we can actually come to a conclusion. So I will start with a very brief introduction of dengue, TB, and COVID-19 epidemiology in Indonesia. And then I will propose a comparative framework and see how we can compare these three diseases and response in light of this comparative framework. And then in the end, I will try to draw some conclusion. So epidemiology of tuberculosis. Tuberculosis is caused by bacteria, Mycobacterium tuberculosis. It is transmitted primarily through respiratory droplets. So hence, it primarily attacks the lung, but it can also be found in any organ in human body, except for hair and the nails, and maybe prosthetic devices that one may use. So Indonesia is one of the 20 countries with the highest TB burden in globally. So it ranks third in global TB incidence in terms of the absolute number. So in 2018, we had 845,000 new cases, and that caused approximately 98,000 deaths. And that comes third after India, which had 2.6 million of new cases in 2018, and China, which had 866,000 cases in 2018. And we also observe an increasing number of drug-resistant TB. So in 2018, we had almost 25,000 cases of drug-resistant TB. So here are a few graphs from stoptb.org. So on the left, we can see that the incidence is quite steady at around 800,000. The treatment rate seems to be increasing. So maybe now around 80% of those with TB are undergoing treatment. And the success rate is quite good. Excuse me. Success rate is quite good. There is a drop here, but I think the main problem is not the drop from those who started treatment, but in fact, there is still a quite huge gap here. Well, 80% is good, but probably not good enough. And HIV, we don't really have that many HIV, fortunately, except for some area, geographical area in Indonesia, but it is not a small number either. So those with TB and HIV, there will be around 25,000 people, and there is even bigger gap to treatment among those with TB and HIV. And we see here that treatment is very bad for drug-resistant TB. So this small dot here, over here, is the cursor there, over there, that's the estimated number of people developing drug-resistant TB, about 25,000, 24,000 people. But currently, those under treatment are about, well, less than 5,000 people. So here on the left, we will see some indicators about notification. So we have quite good notification rate compared to the target. But starting this year and next year, I think, I'm sorry, let me direct you to this number. So in 2018, the target was 570,000, but the target jumped by around 300,000 in just 1 year. And if I'm not mistaken, that was because the change in the estimated number of cases in Indonesia. And initially we thought it was not that high, but then in 2017, we had a study, prevalence survey, and that showed that it was actually higher than expected. So we have now a higher target, and we don't know yet if we are going to actually get all of those cases, but I will show you that we may not. And this is an even grimmer picture on TB that shows this is tuberculosis preventive treatment. So in 2018, we targeted to put 78,000 individuals under tuberculosis preventive treatment. But we saw that this small bar here is the number of individual actually put under treatment. So it was very low, and we have an increasing number of target for preventive therapy for the coming years. And I will show you again later that this may be a little hard to achieve. Why? Maybe among other things, these funding gaps. So this is in US $1 million. So the expected funding that should be available in 2018 was around $300 million US. But I think we only had a little less than half of those, although we can see that the domestic part here is quite okay. So go on to dengue. So dengue is a different disease. It's caused by virus, dengue virus. We have 4 serotypes, namely dengue 1, 2, 3, and 4. That's not a very creative naming, but these are important. This is very important because dengue has 4 serotypes. They are dengue viruses, but they are not cross-protective. I mean, if one was infected with one type of dengue, say dengue 1, that person receive immunity to that serotype, but not to other serotypes. So in theory, one can get infected 4 times with dengue virus. And we observe, and this is a very acceptable observation, that the second the secondary infection, the second infection from different serotype usually results in a more severe disease. So dengue is widespread in Indonesia. It's transmitted by the Aedes mosquitoes, mainly these 2 species, Aedes aegypti, which is a more urban indoor type of mosquito. And then there is Aedes albopictus, which is a more rural and more outdoor type of mosquito. So we have a complete set of Aedes mosquitoes, both who like to be indoor and who like to be outdoor. So basically, we're not safe. We can be bitten by these mosquitoes anywhere. But different from tuberculosis, which has a very steady transmission, dengue has a very strong seasonality. So we can observe outbreaks every year, coincides with the rainy season, the wet season, but then also about 6 to 8 years, much larger outbreaks. As we can see here, the red lines, the red dots, are the incidence rate. So per 100,000 people. And this is this stretch for 5 decades since 1968. We can see that the incidence kept increasing, and here are the 6 to 8 years large outbreaks. But of course, this every year, within a year, there will be outbreaks as well. So it keeps increasing. This may be in part because of a better detection rate, but also contributed or attributed to some extent to the rapid urbanization and population density, an increase in population density, because Aedes aegypti and Aedes albopictus, they like clean water. So with urbanization, but at the same time lack of access to running water, we will observe lots of water containers that are suitable for these mosquitoes to breed. But on the other hand, so the incidence rate kept increasing for the past 5 decades. But case fatality rates is basically very, very low. So in the past decade, it's probably under 1%. Of course, here we had a very huge case fatality rate, but of course, there's a lot of uncertainties for data coming back from the 1960s. And it's everywhere. It is this. So this is from a study from Tejo Sasmono and friends that's showing the serotypes that could be detected from antibody response. So for most places, we could see that the 4 serotypes could be identified from antibody response. In some places, there are only 3 serotypes, but that does not mean the other 1 serotype did not exist, but it's more of the limitation of the serotyping from antibody response. And sometimes, well, often, once people get 2 infection, it's very hard to say which serotype infected that person. So, but basically, it's a hyperendemic, meaning we have all 4 serotypes circulating all over Indonesia. So COVID-19, I suppose you all have been observing COVID-19, and including in Indonesia, it's caused by the SARS coronavirus 2 virus. And it was first identified in Indonesia on March 3rd, 2020. Of course, there's a lot of debate around the actual introduction of COVID-19 to Indonesia, but officially it was identified on March 3, 2020. So this is just a couple of graphs. I think you're all familiar with this. So the last figure, I think we have around 9,000 cases here. So the orange line is the cumulative number of cases in Indonesia. So in just 2 months, we have observed 9,000 cases, which probably too low. But on the other hand, we observe a quite high rate of mortality. So the government at least reported around 700 mortality, or about 8% of all confirmed cases. But here are the number of new cases reported daily. And I just want to show you these interesting up and down. So for example, here we observe a decrease of about 200 cases in just 2 days, but then an increase of 300. So that probably reflects something that I will come back later. And what about the distribution? It's been found in all of in every province in Indonesia, but close to 50% of cases are reported from Jakarta. Does that tell you something? Probably, and we'll come back to that. Okay, so that's just a brief comparative epidemiology for the 3 diseases. So what I'm going to do next is, well, I will attempt to see the response to these 3 diseases in Indonesia. This is a comparative network. I modified slightly from Coker and friends, that basically we can see and compare different disease programs based on the epidemiologic problem, the intervention to that problem, and to explain which mechanism the intervention actually influence the output, and how the output will be translated into outcomes such as the life expectancy, case morbidity and mortality. Of course, we have to see that everything happens in a specific context. And what I added here is that the output is the way I want to see how the output is measured is through the framework called the Cascade of Care. This is a familiar framework if you work on HIV. It's been used in other diseases as well, and it's been used in tuberculosis. So what it is, a cascade of care is a cascade that describe how people go through different stages from being seen at the health facility and to finally get treatment and be cured from the disease. So I illustrate here that it's a cascade because rarely it happens that all cases are seen and treated and cured from the disease. So this is how I want to try to compare these three diseases, but I will probably will be focused more on tuberculosis because more work had been done on tuberculosis compared to the dengue and COVID-19. So just a little bit of context. Indonesia, I think we are all familiar with these numbers. We have now around 270 million people. We have young population. But from health expenditure, we are quite low compared to other countries in Asia. So this blue line here, this is from 1995 to 2014. The blue line here is for Indonesia, and then it is well below other countries such as Malaysia, or here the stripe is Republic of Korea, of course. Okay, so what about access? So health workers per 1,000 population, and this is until 2014. I would like to direct you to this red box. So in 2014, the ratio for physicians for every 1,000 population was less than half. So we have less than half doctor for 1,000 people. We had more nurses. I don't know how come the nurse ratio went down here, and I don't even know what happened to these three professions. I guess it's just a matter of reporting and enumerating, because I don't think sanitarians, nutritionists just went missing from Indonesia. But basically, this is just showing that we have a very low ratio of health workers per 1,000 population. And I think even worse, if you see this table here, and both from the same publication by Mahendra Datta and friends about Indonesia Health System Review, these resources are not evenly distributed. Probably it's quite evenly distributed among the big islands in the western and central part of Indonesia, but we can see here that Maluku, East Nusa Tenggara, and Papua only had 0.03 doctors to 1,000 people, compared to 0.4 to in Sumatra and Java and Bali. Okay, so that's just brief. I think that gives you a context that in general, we are under-resourced for health. So TB and dengue, the cascade of care. So I will start with the cascade of care of TB and dengue to the best that I can. So from the National TB Inventory Study, and I combined this with a different report from 2020. So this is not directly comparable, but I'm sure this is not widely off. We can see the cascade of care. So if there were 800,000 cases, that's one. We don't know exactly how many of those were seen by healthcare providers, because nobody actually knew the first time they saw somebody that person was actually had TB, unless that person gets diagnosed. But what's the proportion of all cases that gets diagnosed? So for TB is around 80%. But from these 80%, we only know about, so the dark blue here is the proportion from total, and the lighter blue is the proportion from the previous step. So from all of those cases diagnosed with TB in Indonesia, only around 65% were notified to the health system, meaning we only know the fate of these 65% of cases, or about 52% of all cases. So from this number of cases notified to the health system, about 70% was put under treatment, and about 85% completed treatment. Okay, this is not bad, But if we look in comparison to the total number of cases, we only have approximately 30% of all cases completed treatment for tuberculosis. What about dengue? Dengue, this is from a study by Wahyono and friends, and this is mostly looking at epidemiological data and eliciting consensus among experts about the rate of diagnosis and the rate of hospitalization among dengue cases. And dengue is different from tuberculosis, very different. Dengue is acute infectious disease, and tuberculosis is a very chronic disease. Usually when people get sick of tuberculosis, they get more severe as time goes by. But dengue, many people get mild dengue and even asymptomatic dengue. So most of these people who were seen at health facilities are those that who had severe or more than, well, somewhat severe dengue manifestation. So that would be around 50 to 60%. But not all of those get diagnosed, because dengue can be mistaken with many other diseases, influenza, for example. So only about 70% of these cases gets diagnosed, but only 50% of these cases gets notified. Why? Because not like tuberculosis, only severe dengue gets notified to the health system.
Sorry, Panji, can I ask a question?
Oh, sure.
Yeah, so first, can you explain again the difference between those two colors? And second, yes, if the next columns explain the portion of the column before, if my understanding is correct, how come, for example, in dengue case, the diagnosed bar for the lighter blue one is higher than the seen one?
Yes.
Thank you.
Sorry. Okay. Sorry if I was not very clear about that. So the darker blue bars are proportion of total. So the baseline is this one. So the baseline was the first column, all cases. But for the lighter blue bars, it's comparing the current stage with the previous one. So for example, this means 70% of all cases seen. So 70% of this, 50% of this one, 100%. So this is relative percentage, relative proportion from the previous stage. While the darker blue is a relative proportion from all cases. Yes. Okay.
Thank you.
So I think it's useful to see the lighter blue and interpret that as the gaps between stages, not from all stages, not from all cases. So, okay, so let me go back here. So I guess not all dengue cases require treatment. Only those who are severe enough requires hospitalization. But there is no, unlike tuberculosis, there is no specific drugs for dengue. So the treatment that we have are mainly supportive in terms of providing fluid and just to keep the general condition of the patients to be stable. We don't have data about how many cases completed treatment here. But I think in general, we can see, to compare the darker blue bars, that there is a huge drop from all cases of tuberculosis and dengue to be seen in the health facilities, gets diagnosed and gets treated. So there are gaps between the stages in the cascade of care. And why? And what are the intervention and what are the mechanism that gave rise to those gaps, and what are the interventions that can be used to close those gaps. So, for example, in TB, why did cases not seen in healthcare providers? Well, we have problems of access to care, the same as dengue. But for dengue, maybe many people did not go to seek care because they develop only very mild symptoms, and understandably, they don't feel the need to go to healthcare facilities. But then, if somebody with tuberculosis or dengue comes to healthcare facility, why didn't that person get diagnosed? Well, there is also a problem with access to diagnostic. For dengue, for example, to diagnose dengue, you need some kind of antibody testing or antigen testing. They are usually not readily available, especially in puskesmas, in community health centers. We don't have those diagnostics. For TB, the access to diagnosis is much better because a good majority of puskesmas in Indonesia are well equipped, at least with microscopes, to diagnose tuberculosis. But I will show you again later that Indonesian people don't always go to puskesmas, as they don't always choose puskesmas as their first choice of healthcare provider. Many people go to private sector, and in these private sectors, especially private practitioners, clinics, small clinics, they don't really have access to diagnostic, as well as treatment. TB treatment, for example, are available for free in puskesmas, but in private sectors, they have to pay for that. And the vast majority of the private sector do not have this access to free TB drugs from the government. Of course, we can move on, but let me just discuss briefly. Treatment completion can be affected by access to treatment. For example, tuberculosis. In tuberculosis, we have the directly observed treatment strategy that basically assigns somebody to supervise the patient to have the medication every day. But probably in the private sector, for example, they don't really have access to that treatment. So the patient do not get observed directly, and hence lower adherence. And patient behavior that plays a part. Notification system, I will show you how complex the notification system is. And for private sector, that really hinder participation because that's a lot of work. And this is something that I did not discuss previously. Preventive action. For tuberculosis, we have vaccination. I think we have a quite good rate of vaccination. But preventive therapy, it's severely under, I think we have a very low coverage of preventive therapy in tuberculosis. For dengue, it's mainly relying on community participation. So let me try to show you some statistics about from this table. For the first one, access to care. This is a graph showing median distance to nearest healthcare facility in Indonesia. Well, this is from 2011. I think things are getting better now, but probably not going to be a drastic improvement. But this serves as a very nice illustration that for Indonesia in 2011, on average, the nearest distance to a healthcare facility was about 5 kilometers. Well, people who live in Jakarta, we have quite good access, less than 5 kilometers. But in places like West Papua, Maluku, it could take more than 30 kilometers to access the nearest health facility. And I think we're not talking about 30 kilometers by land travel. It's probably between islands. So we have to take a boat to a different island to access healthcare. So this is a very nice illustration about discrepancy, about inequity into healthcare access. What about access to diagnostic? So even though one has access to healthcare, that doesn't mean that that person has access to diagnostic. For example, this is from study by Surya and friends using patient pathway analysis to see how TB patient gets diagnosed and gets treated. Well, what's interesting is that only about 19% of patients had access to diagnosis at their first visit. But the rest, more than 80%, must be referred to other healthcare facilities. So that lower the chance of getting diagnosed, actually. And this is a study that we did. It's still unpublished, but it's showing you how complicated to get diagnosis for TB and getting treatment. So these are different pathways to diagnosis. So if you or if somebody comes to private practitioner with TB, that person may not be diagnosed there, but diagnosed at some other place, probably, for example, puskesmas, community health centers, or hospital, either public or private. But that person can go anywhere. Before finally, that person may get referred again to get the treatment. And this is very complicated. On average, a TB patient needs to have 6 visits before that person gets diagnosed with TB. So 6 visits to different healthcare providers before the diagnosis is finally made. The median, sorry, not the mean. And what about patient perspective? What caused those things? Well, many things. And this is drawn from very small number of people, 11 cases. But I think this describes very nicely what we observe on a daily basis on TB cases. Yeah? There are issues of TB awareness. There are issues of influence of others, including stigma and fear. We often find patients did not access the nearest healthcare facility because that person did not want to be known to have TB by their neighbors. There's issue of treatment quality, treatment barriers, and then all of these factors that may influence how people behave to the disease. Oh, okay, here comes reporting. This is the mechanism for reporting a TB case to the Ministry of Health. So the text in red are the forms that one needs to fill out in order to report a TB case. Of course, so for example, this is the polyclinic, the clinics. At the clinic, the form that needs to be filled out is TB06. It will be sent to the lab along with TB05, and then the lab will fill out the TB04. Results will go back to the clinic, and then if it was positive, the patient would be recorded on TB01, and the patient would go home with TB02. Now all of this will be summarized on TB03. If referral was needed, then the hospital, for example, from hospital back to the puskesmas, then TB05 needs to be filled, and then TB09, the patient needs to bring TB09 to other facility. This other facility will be required to fill out TB10 and return this form to the hospital. Well, so at least at the health facility, at the primary level, there are at least 12 different forms to be filled out. Okay, I will just skip this one. And it's very complicated. For dengue, it's different, but I think in principle, not very different. It's quite complicated. Okay, so we'll finally come to COVID-19. So I don't currently have a nice estimate of the cascade of care, but I think these graphs can show you the gaps between diagnosis and treatment. So again, the blue line here is showing the number of cumulative cases in the past 2 months. The question is, have we seen all cases? And I think this has been asked many times. Well, most likely not. We currently have more than 200,000 of possible contact under observation. And we have more than 20,000 of people suspected to have COVID, but not yet laboratory confirmed. Why? Because here we can see that although we have an increasing test ratio, but it's still under 0.2, under 0.3 tests per 1,000 people compared to, for example, the US, South Korea, Republic of Korea, that has much higher testing rate. So probably we're not seeing a lot of cases at the healthcare facility. What about treatment? So if they're not diagnosed and they will not get treatment, if they don't come to the health facility, they will not get treatment. But we can see here that we have deaths. We have 8% deaths among those confirmed with COVID-19. So that's quite high proportion of deaths compared to other advanced countries. That probably show lack of, well, probably severity, that reflects severity of cases that comes to the health facilities, but probably as well that reflects the access to required critical care and required medication and expertise to treat the patients. And this was published a couple of days ago on Reuters, raising the issue about suspected deaths or deaths among suspected COVID-19 patients. So at the moment, the government reports around 700 mortality from COVID-19. But if you look at the number of deaths among suspected cases, it actually count to more than 2,200 deaths. So if, for example, I think the one estimate estimated that for one death, that would be there would be 400 cases, or 400 to 500 COVID-19 cases. So this probably, although I'm sure this not all of the suspected cases are actually COVID, but I think it is a good indication that we're underreporting cases, that we're not detecting cases of COVID in Indonesia. So we may have many more cases, and that goes unseen and undiagnosed. And we can see here, access to care and diagnostic. These are quite crowded picture, but I think what I would like to direct you is to these two numbers, hospitals and PCR. We can see, for example, for Jakarta, there are 13 referral hospitals for COVID, and the government enumerate at least 7 PCR machines. And that's for DKI Jakarta, relatively small area, although densely populated with about 10 million people. Compared to West Java, Jabar, Jawa Barat, West Java has 34 referral hospitals, but only 4 PCR machines. And West Java is a much larger area with about 40 million people. What about Papua? Papua has 1 PCR machine and 15 referral hospitals. What about Central Kalimantan? 0 PCR machine. So, and this is, we're only talking about PCR machine. We're not talking about the machine required to extract RNA from COVID samples. And we're not talking about supplies of reagents. We're not talking about testing kits. And there has been report about backlog of examination because these labs were running out of reagents to run the test. And but on top, I mean, in addition to PCR, though, Indonesia is also distributing rapid tests all around Indonesia. Yeah, but is this enough? For example, rapid test is the green number here. For West Java, it about 30,000 test kit was distributed. I'm sorry, this was cut. For Aceh, it was only less than 5,000 kit distributed. Of course, Jawa, I think at least for the moment, it bears the bigger COVID-19 burden compared to other places in Indonesia. But is this enough? Probably not. And what about people behavior? This is also something that we observe for TB. Much less for dengue, but for TB, we observe stigma, and it is very unfortunate that there seems to be a very strong stigma related to COVID-19. There was a nurse that was rejected to be buried in Central Java. And then there was nurses being evicted by landlords because the landlord fears of infection. And patients lied to the physicians about their travel history because they did not want to be suspected as having COVID. And in effect, 46 medical workers were exposed to COVID-19 because that patient did not reveal his or her travel history. What about reporting? Well, this is also a little complicated, I think. I did not bother to translate this to you, but I just want to show you that this is not very straightforward. And maybe I will direct you to these orange boxes that show you the means of reporting. It could be you can use telephone, SMS, facsimile, email, many ways. I don't think these are standardized, and there are chances, and actually the COVID-19 task force already confirmed that there were data discrepancy between central regional governments, and I think we can see why, because it's complicated. Now, what about preventive action? So I think the main response to COVID-19 now is through social distancing. There was a big debate about whether Indonesia could impose a lockdown. That took the whole March. And finally, on April 3rd, regulation on large-scale social restriction, which is among quarantine action that could be taken by the government, was finally enacted. Meaning the only acceptable preventive action in terms of social restriction is large-scale social restriction instead of area quarantine. That is not acceptable because that is not regulated. So the way we can do that is the regional government must propose the large-scale social restriction to the Ministry of Health to be approved by the Ministry of Health by showing evidence that this intervention is actually necessary. For example, showing the epidemiological evidence that that region already had sufficient number of cases for such intervention to be taken. And then a few days ago, the president finally banned Mudik, our annual tradition of homecoming or going home from wherever we are now in celebrating the Lebaran after the fasting month of Ramadan. And PSBB, the large-scale social restriction had been enacted in Jakarta, West Java, and Sumatra, Bandung. But the effect, well, Jakarta report of that they have observed an effect, a slowing down in the number of cases, but I think that remains to be seen. Because in practice, although the Mudik has been banned, people find ways. So you cannot travel by your own car. So instead, they put the car in a truck and then they can travel by other means. Necessity is a matter of invention, I suppose. So what can I conclude? Well, I think from this cursory comparison of these three diseases, I think I can say that COVID-19 seems to be suffering the same fate as TB and dengue. So, but especially we are not detecting cases. Without good detection, then how can we have a good intervention for those cases? And I think the response also suffer from the same problems as the TB and dengue. We lack resources. We don't have enough capacity to test. We don't have enough, we don't have enough protective equipment, which is a common problem everywhere. But there is a problem in Indonesia. We have lack of access to care, to diagnostic, and we have lack of public concern. I think in the first week of the large-scale social restriction, there are still reports of market being crowded by people, and many of those didn't even wear masks, and let alone practicing social distancing. So, will COVID-19 be the next TB or dengue? Well, I think it's not unlikely, and there's probably no surprise there. But what does that mean? I think because being the next TB or being the next dengue means differently. TB is, I think, in my opinion, TB is quite a good condition. It has a dedicated program to control the disease. But dengue is pretty much neglected. Will COVID-19 has the attention that TB currently receive, or will COVID-19 be neglected like dengue? It's hard to say. I cannot predict the future, but for now, COVID has no specific drugs, has no specific vaccine available. So I think it's a little hard to get the level of attention that TB gets at the moment. Because TB, one thing about TB is that it's easy to diagnose, not that easy, but relatively easy. And there is proven effective treatment for TB. So maybe COVID will be the next TB or the next dengue. That's quite pessimistic. But unless our current response can also strengthen the health system, although I don't know if that will be likely, or a vaccine is available, because vaccination coverage is generally good. But again, it's a different issue from having a vaccine available and having it available for Indonesians who need it. Usually it takes years from the year that the vaccine is available to the day that the vaccine is available for Indonesian. It may take, for example, in the case of Haemophilus influenza B, it probably took around 15 years. So I think that's what I can present for today. I look forward for the discussion, and back to you, Pak.
Thank you very much, Panji. That was very interesting and insightful. Let us go to question and answer session. But I see Dr. Panduryono in the audience. So Dr. Panduryono also gave a talk in our previous webinar on this issue. So I might want, if Pak Pandu is still there, can I ask you to maybe give some comments or one comment or two on this presentation? Pak Pandu, are you there? Okay, silakan Pak. Yeah, it's a bit, can you speak louder? Pak Pandu? Okay, while we are waiting for Pak Pandu to maybe fix the audio, there is a question from the floor from Wisnu, Pak Panji. He asked why there are so many TB forms that need to be completed. Okay, wait.
Ya kan itu udah kita bisa. Tapi kan itu kan baru penurunan kita harus capai gitu dengan menahan diri sementara. Karena kalau kita tidak sudah melaksanakan krisis.
Pak Pandu, you are muted.
Yang perlu kita pahami bahwa kita itu bisa cepat menyelesaikan pandemi ini sesuai dengan target yang sudah ditetapkan. Iya, jangan mau kita dijajah oleh virus corona.
Baik Pak, oke, thank you Pak Pandu. So let us go to the next question. Pak Panji, there are questions from Wisnu.
Pembatasan akan selalu ada.
Yeah, Pak Pandu, we're going to answer questions first from Wisnu, asking why are there so many TB forms that need to be completed?
Well, I've been asking the same question. Yeah, I don't know why the program needs to have that many forms. Yeah, of course there are many variables that's required for a good reporting, but I think it's just very complicated. Well, of course now we have this online system that's a brand new online system. I think it didn't start until a couple of months ago. But yes, it's still.
But how is it being handled in other countries, for example? Do they also have that many forms?
That's a good question. I have never done a comparative study of reporting, unfortunately, Pak. But yes, what we've been trying to do is to simplify the reporting, especially for private sector, private practitioners, because the administrative burden for reporting is very high. If you see just, for example, the patient registry, the TB01 form, has a lot of variables in it, including the name of contacts within the household and results of diagnosis, and most of the time a private practitioner, especially those who are practicing by himself or by herself, will not have enough time to fill in that form. So what we've been, I think, in other countries, well, yes, the reporting requirement is quite huge, but there are models that have been tried to also employ third party. So intermediary organization to help the health facilities completing these forms. I think that can be used. And for I guess this is not a problem for Puskesmas because they are very used to this requirement, but for the private sector, it's a huge problem.
Okay. There's a question from Professor Terry Hall asking if you can comment on this. What are the strengths and weaknesses of leadership of the national and provincial health services in the past 3 months?
In the past 3 months?
Mm-hmm.
Can you repeat that? I'm sorry.
So the question is, what are the strengths and weaknesses of leadership of the national and provincial health services in the past 3 months?
Okay, and I think this is referring to COVID-19, yeah?
Yes.
Okay, let me start with weaknesses because I think that's easier to address. For one, I think we can all agree that we have observed lack of leadership. So COVID-19 was first identified late December, early January in China. And I think in January, we already observed a number of publications describing the extent of the transmission of COVID in Wuhan. But I think in February, the government did not give any serious consideration. I still remember that on the, I think February 14th or 11th, there was a publication that basically estimated or predicted that Indonesia should have had cases of COVID-19 from late January. And the Ministry of Health dismissed that hypothesis and even calling that conclusion to be an insult. So we did not give sufficient consideration for COVID. And of course, the role of leadership is very strong here, or the lack of it. Yeah? And even until now, I think in the past 3 months, there's been lack of coordination, and there is a lot of regulatory barrier that was not resolved in a timely manner. For example, the month-length debate of lockdown was basically boiled down to the problem of not having regulation for locking down an area. So we have a law that regulates quarantine efforts, but for that law to be enacted, we need to have specific guidelines. So in that law, there are 4 different types of quarantine efforts. The large-scale social restriction, and then the house quarantine, hospital quarantine, and area quarantine. So the debate about locking down Indonesia is the debate about having area quarantine. And nobody could do that legally because there was no regulation available to regulate area quarantine. So after a month, the government decided to write the regulation on large-scale social restriction, meaning the only legal quarantine effort that can be done now is large-scale social restriction, not house quarantine, not hospital quarantine, not area quarantine. So that shows a lack of organization. And that's only from the public health perspective. And I think we have heard issue about stimulus response, economic response. For example, for the social aid for those who are needed. So we also see lack of coordination in that part. So, and that is for the central government. So I guess that void of leadership and organization really makes it up to the provincial and to some extent the district level government, the district level health offices to take lead. So we can see, and this is very clear from the beginning, that Jakarta tried, the governor tried very hard to take the lead and do his best to protect Jakarta from COVID-19. So he proposed very early to lock down Jakarta, but of course it was not on the table. And now West Java, the governor of West Java also can be seen to take the leadership, at least for West Java, to take care of COVID-19. But of course, this is not good because we don't have Anies Baswedan, we don't have Ridwan Kamil, we don't have Ganjar Pranowo or Bu Risma in every provinces, in every district in Indonesia. So in Bali, for example, I think the local government has played down COVID-19 as well. And of course, we haven't seen a surge in cases, in COVID-19 cases in Bali, but there seemed to be a lack of concern, from political concern in Bali as well. So I think that's what I can say about the government.
Yeah, thank you, Panji. I think you have just also answered the question from Pak Halhil about the coordination between the levels of government, central, national, and province, and also kabupaten. So let's move to another question. And there's a question from Jordan asking about managing the priorities. So how do you think the government can actually deal with this COVID-19 outbreak, while at the same time they still have to also manage the TB and dengue?
That's a very good question. And I will not pretend that I can answer every question here, Pak. That's a very good question. And I think already we can see that other health programs are suffering because of COVID-19. Yeah, because in practice, especially in areas where we observe lots of COVID-19 cases, the hospitals are practically services are being diverted for COVID-19. So we have received reports about people with TB having difficulties in accessing treatment because some of them needs to go to hospital. For example, for drug-resistant TB, they need to go to hospital. And at the same time, so up to date, we already observe or there has been about 50,000 dengue cases reported. So we are also having a dengue outbreak at the moment. And there seems to be little attention put to dengue because, well, there's COVID-19. And for some hospital, for example, in Bandung, Hasan Sadikin Hospital, they transform one building that used to be internal medicine ward, and they reallocate that building as a COVID-19 isolation building. So obviously that means the effective capacity of health facilities, of health system to treat and to manage other cases is being reduced at the moment. So it's very hard to say. I think there is an urgency in managing COVID-19 because we are talking about the possible very bad outcome, large number of mortality and morbidity due to COVID-19. So there is an urgency, but I think there is also an urgency to plan for continuing services for other conditions, but I think that hasn't been seen. So yes, it is a very good question. I think something that we need to address very soon, sooner than later.
Thank you, Panji. Before we go back to the Q&A, can I check with Pak Pandu again? Pak Pandu?
Okay,
Okay,
yes,
now
I'm ready.
the voice is good, Pak. Please.
Okay, thank you. Good afternoon, everybody.
Good afternoon.
Yeah, this is the opportunity that Kang Panji is already. I not criticize Kang Panji in virtual. In daily life, I only criticize him. And actually, he also did a good job to realize that Indonesia has a lot of problem, especially in pandemic. The real problem is neglected because of every sources good to overcome the pandemic situations, even basic immunizations and many childhood program like Posyandu is become decreasing the activity. And if we neglected the immunization, is very worry for us, because this is the immunization should be very should be timely given to the child based on the age. And if we fail to do that, it might be we can see the next outbreak should be prevented by immunization. It means we should not neglect some basic health services. But in reality also, some puskesmas has trouble with COVID and they closed because some of the nurse or doctor got infected, and even some hospital is closed because they have some problem in many hospital worker there is like doctor, nurse got infected. This is a real problem that actually because we fail to alert all the healthcare worker in all Indonesia should using their protections equipments, personal protection equipments, and alert with the possibility that their patient, it might be also a positive carrier. That means that we should prevent this, and it's very difficult for us if all the, even the primary health care also got damaged by collateral damage, and we focus on the hospital and puskesmas neglected, and but they still provide the basic health services that it should be managed, and also by attention by government, how to maintaining the public health services in puskesmas. Because if we can beyond this after pandemic, if primary health care is become damaged, it's difficult for us to strengthening the capacity, especially the primary health care. This is the I think the Mas Panji or Kang Panji that should be mentioned, that multi problem even come together, then how we dealing it, but we not on focus only one problem. We should focus the daily problem or the there, and maybe mix with the COVID, because dengue and also some patients dengue also already also infected by COVID, and make difficult for us to provide a good quality services. Even before pandemic, we had also trouble the weakness of our health services, even the weakest link that Kang Panji already mentions. Our weakest link is laboratory diagnostic. That's the problem also. The patients, if they go to primary health care or go to the private doctor, it's very difficult to diagnose, because they should sense to refer to the hospital or the other institution to get diagnosed. This is the problem that become reality also when we're dealing with the COVID, because we not expand the laboratory diagnosis. This is my comment that maybe already cover a lot and comprehensive by Kang Panji, and I just give some adding more. Thank you.
Oh, that's very good, Pak Pandu. Thank you very much. Before we go back to Panji, let's go to Q&A again. There's a question from Rani Aulianti about the possibility for Indonesia to learn from other countries such as Germany, New Zealand, and Vietnam. I understand now you are in New Zealand, Panji. Maybe you can tell us about this. And the question specifically is how we use these lessons from other countries to deal with COVID-19, since those countries claim winning the COVID-19. So why don't we do something like what they did?
Yeah, it's a very interesting question. I think the more interesting question is, why haven't we? I mean, Italy did what they did, the UK did what they did, New Zealand did what they did. So all the lessons are out there, but haven't we learned? I think it's a very confusing fact to me. Are we not learning anything? Although, yes, we are, of course, Indonesia is not New Zealand. Indonesia is not South Korea. We have 15,000, more than 15,000 islands, probably 7,000 of those inhabited, 270 million. We are not as rich as these other countries. So, but in any case, we can still learn from Vietnam, for example, who are probably more in par with Indonesia, but is more successful in controlling COVID-19. I'm not very sure why, but I can probably guess that it's a matter of priority and agenda that was prioritized by the government, and I should say probably by government meaning President Jokowi. Yeah? And it was very clear that in the beginning he was highly focused on the economy, which is a good thing. Focusing on the economy is a good thing. It's not a bad thing, but it's probably it was probably disregarding the fact that we're facing a pandemic. So I think we are a little late in doing what we should have done many weeks ago, but we can still learn from other countries. But of course, there's a lot of things need to be adjusted because of our geography, because of our social and political culture. But that is very true. We need to learn, but more than that, we need to act. Now, well, the social restriction has been enacted, but I think from many reports, people are just still living their life. So I don't know the answer to that, unfortunately.
Yeah, related to that, speaking of learning from what we have seen, there's a question from Professor Budi Reso Sudarmo. He's asking how far we are in terms of our ability in managing COVID-19 issue. Sorry, my daughter. Compared to the other epidemics. So for example, in terms of reporting, treatments, and community understanding, is it possible to do the easier first? For example, similar procedure on testing and reporting, etc. So learning from what we have done with TB and dengue. Do you get this, Panji?
Yeah. So I think, thank you, Pak, and thank you, Pak Budi. I think from what I learned from putting together this presentation is that we're actually not learning from our experience with TB and other diseases. And one thing is that we are under-resourced. And one thing is that, the other thing is that we haven't been successful in controlling those diseases. And I think if we have asked why we did not succeed, we have not succeeded, and use that answer to help us in dealing with COVID, maybe we could have been in a better place today. But yes, we haven't learned. Yes, we can do things that are easy, but I think for COVID-19, the best options are not the easy options. I think as we can see here in New Zealand, in Australia, it was the hardest choice that could be made, that was taken, that could finally control COVID-19. So I think if we're dealing this extraordinary case in an ordinary business as usual manner, then, well, we are welcoming COVID-19 to be the next TB, the next dengue, I think.
Still related to that, the question from Lydia Napitupulu. She said that even without stigma and complicated reporting, it's very unlikely that all these cases can be dealt with given the current capacity constraints. So her question is there an alternative to going through the cascade of care for an improved outcome?
I'm sorry?
Alternative to going through the cascade of care that you mentioned for an improved outcome. Yeah.
To improve outcome. Yeah. So I think improving outcomes, meaning that we need to be able to treat as many cases as possible. So, well, there are two sides, I guess. Yeah? The first one is, of course, dealing with cases, meaning dealing with people who have the condition. And for that, we need to complete the cascade of care. We need to see the patient. We need to see the cases. We need to diagnose them and treat them, and then make sure that the treatment works, they can complete the treatment, and the treatment has a favorable outcome. So for those who have the condition, I think we don't have any choice but to complete and improve, close the gaps in the cascade of care. But of course, there is another side, which is the prevention side. And that can be done, and that should be done. And that was, well, aimed to be done, although probably did not get the attention it should have, to prevent the disease. So tuberculosis, well, we have vaccination, we have preventive therapy, but I think currently less than 5% of those eligible for preventive treatment are put under treatment for preventive treatment. And then there is improving social determinants of health, improving social condition, improving living condition, improving income, improving education. That can be done. And I think that can have, although probably not immediate impact, but a very long and a very strong impact on health later. Back to you, Pak.
Okay, thank you. I'm going to use my privilege here to ask question, Panji, if you don't mind. So, in the beginning of your presentation, there is this very interesting graph of population pyramid, right? So the demographic. I see here Ibu Meling is in the audience too. So let me ask this question. Maybe she can jump in also later on. So I just read a commentary this morning about the case of India. So they said that in general, India's population is still dominated by younger people rather than the older ones. And then we know from all this news and also seminars that actually COVID-19, most of the victims are older people, right? And this commentary that I read this morning saying that probably lockdown is not the best policy in India because after all, the demography is mostly still young population, and young population actually is the backbone of the workforce. So they need to work and to to be able to support the economy again. So I just want to, I'm for lockdown and I'm for the social distance, but I just want to listen to your comment on this.
Okay, thank you, Pak. And there is a no yes or no answer to this, and there's a continuum of possible policy options. Yeah, but I think it's incomplete to just talk about the age structure because we are talking about infectious disease. An infectious disease is special because a case is not a case. It's not only a case, but it's also a source of transmission. So yes, if we're talking about the age structure and assume that young people get milder disease, I think that's so far acceptable as an acceptable assumption. But we cannot stop there because even though they get mild symptoms, they don't get severe disease, they still serve as a source of infection. And they can go back home and see their parents, their grandparents, and they will be the vehicle of transmission to these other high-risk age groups. And of course, we're not talking only about risk related to age or age-related risk. We're also about we also need to see that the risk of severe illness increase as people have comorbidities. So, and even young people have hypertension. So if that increases the risk of severe illness from COVID-19, then just letting the disease go around the population, that's probably not a good idea. Of course, there are ways to control the transmission. There are ways to that may serve both the economy and public health. But I guess it's going to be different from country to country. If India thinks it's not a good idea, then maybe they we are all learning part here. So if India wants to take one policy, then maybe we can just observe what will happen to India and we'll learn whether that would be a good idea or not.
Thank you, Panji. So let's go back to question and answer. There's a feedback from Yoel Setiawan. He says that PSBB or massive social distancing should be undertaken in epidemiology areas, not really in administrative areas. The idea means that PSBB is supposed to be carried out across the whole Java Island as the initial transmission of COVID-19 derives from Jakarta. Mm-hmm. So the central government needs to work concurrently with regional government in applying this policy and preparing necessities for social distancing in undetermined time. So do you get this, Panji? So
yeah,
the whole Java.
Yeah. Yes, yeah. And it's a very good comment and observation. And I agree. I think one thing that we have that can be considered as an advantage is that we have islands, and this disease does not recognize administrative borders, but I think it does recognize land barriers, geographic barriers. It's not going to jump to other islands just like that. So I think it's probably a good idea to see islands as the epidemiologic area or the epidemiologic border for controlling COVID. But again, the problem is that the way our country is approaching the control to COVID-19 is to let the local government take the initiative, but keeping the authority at the authority to approve at the central government level. So if I think it's a good idea to have a PSBB to do the social distancing for the whole Java and Bali, for example. But what needs to be done is that the local, all the governors in Jawa, they need to talk to each other and let's do this together. And then for each government to talk to all the head of districts under his jurisdiction and to have their cooperation to run this together. But again, because if you see the requirement to enact the large-scale social restriction is, among other things, is to show epidemiologic evidence that will justify the large-scale social restriction. Then probably some districts don't have this requirement met yet because they have not observed a lot of cases. So I think it's a very, I guess the biggest barrier to COVID-19 control for Indonesia is the bureaucratic barriers. It's the regulatory barriers as opposed to, I think that's what.
Thank you, Panji. So our time is up actually, but let's take the last question from Heath McMichael. What do you think about the herd immunity argument, Panji?
Okay, as an epidemiologist, I think COVID-19 has brought a bad name to herd immunity because herd immunity as a concept is a good thing. Herd immunity protects us from disease to get transmitted, from disease outbreaks. That's the idea. If a sufficient number of people have immunity to a disease, then the disease wouldn't find people to be infected because, you know, it will bounce off and transmit it to a protected individual. So as a concept, it's a good thing. But what has happened is that some politicians, I guess, use the term herd immunity as a strategy that means to let the disease loose in the population and in effect provide natural immunity to that large number of people. So yes, herd immunity is good, but insofar as it's achieved through vaccination, not through natural infection, because with natural infection comes also a large number of mortality. So that's what I think.
Okay, thank you so much, Panji. It has been a very a good discussion today, and I would like to thank also participants, especially Pak Pandu, and also for those who raise questions. I hope we answer your question. For those whose question is not answered yet, maybe we can discuss some other time. But the time is up now, so let me thank Panji again one more time. I hope you will be able to go back to Indonesia soon.
And thank you, thank you, Pa, and thank you for the NU Indonesia project for having me.
Okay, so thank you everyone. So let me give this back to Nuke.
Okay, thank you. I'm just going to close the session now and see you next week, hopefully.
Thank you.
Bye.